Good afternoon. I'm Victor Schaffner, Director of Communications and Advocacy with the University of Delaware's Center for Disabilities Studies, and it is my pleasure to welcome you to today's Lunchtime Learning Zoom webinar, The Imperative of Mental Health Literacy. Annie Slease, CDS's Strategic Manager of Mental Health Initiatives, will be presenting. Thank you for joining us. At the completion of Annie's presentation, there should be time for her to answer several of your questions. If you wish to submit a question, you can do so in Zoom's chat field by typing or by using speech-to-text dictation. I, along with another member of the CDS team, Tabitha Grow, will then pose some questions in the time we have remaining to Annie. Today's event is being live captioned. In the coming days, we expect to load a captioned video of the event to YouTube and our websites. Also, at the conclusion of today's lunchtime learning session, you will receive a brief survey that asks a few questions about the webinar. We ask that you complete it and send it back to us today or tomorrow. Annie Slease works on mental health initiatives within our center's school age and health and wellness units. She leads efforts to increase mental health literacy, reduce stigma, strengthen crisis response and treatment systems, and identify and implement upstream solutions for early intervention. Annie came to CDS from Delaware's chapter of the National Alliance on Mental Illness, NAMI Delaware, where, as Director of Advocacy and Education, she was responsible for educational programming, community outreach, and policy advocacy. Before NAMI Delaware, Annie was a classroom teacher for 25 years, mostly teaching language arts in middle grades. Thank you, everyone, once again for joining us. I'll now turn things over to Annie.
Hello, I'm happy to be here. So hopefully everyone can see my slides. Great. So I'd like to start with a quote from Brené Brown. Sometimes the bravest and most important thing you can do is just show up. And you have. Maybe you're wondering, how does this topic relate to you personally? How does this topic relate to someone you care about or the work you're doing? Today, as you show up for this topic, I invite you to focus on curiosity, kindness, perspective, and self-compassion. Because these topics that we discuss may be new, or perhaps they're familiar, but explored in a new way. And there may be something that we talk about that generates strong feelings in you, possibly activating personal or professional memories. Please take care of yourself during our time together. And as we begin, I'm going to share a little bit about what brought me to this work, my why, to help frame why this issue of mental health literacy is so important, not just for me, but for all of us. The imperative of mental health literacy connects to everyone, and it's personal for many of us. But first, I want you to know two things. First of all, my children, who are both adults today, have given me permission to share what I'll share. And as part of our story, I will make mention of two sensitive topics: thoughts of suicide and accessing means by firearm. So please do what you need to do to take care of yourself today. This is a little bit about me, how I see the world, and some of the roles that I've had. So my name is Annie Slease. I use she, her pronouns. I have light skin and medium length brown hair. I'm a cis straight woman and a member of the Citizen Potawatomi Nation. And I strongly identify with my Native heritage. I'm the parent of a person with serious mental illness who has been justice involved. I have two children, shown here in this photo from many years ago. They have light skin and short brown hair, and that's chocolate on the little one's face. They're both adults today. And I have 3 stepchildren too, and they're all adults now as well. And I have a grandchild who turns 1 in December. As you heard, I was a classroom teacher for 25 years, and I did teach mostly middle grades language arts. I also launched and led the musical theater program for my middle and high school. But during those years, when I was raising 2 teenagers, my older child at age 18 experienced significant mental health distress. And we didn't have the knowledge or the resources or the confidence that we needed to prevent devastating consequences. My older child didn't understand what was happening. He hadn't learned about this in school or from me, and figured it must be personal weakness, a flaw, something to be ashamed of, something to hide. And despite my education and my years of experience as a teacher, I didn't know how to navigate this either. My child's needs worsened, and the outpatient help that we found wasn't enough. So my child made plans to die by suicide and brought home a loaded firearm. But my younger child, at just age 13, found it first. I'll stop there to tell you that no one was physically hurt that day, for which I'm forever grateful. But looking back, that day was really significant for us, not just because of the tragedy that we were able to prevent, but because of the many tragic outcomes that would eventually follow. That day marked in many ways the beginning of our story. My child would go on to develop substance use disorder as a means to quell symptoms, leave home, experience homelessness, and ultimately be incarcerated for nearly 3 years as a result of unmet mental health needs. And years later, the challenges have continued. Struggles with recovery, finding employment, reliable, affordable housing, maintaining relationships. Our family, like so many families, and my child, like so many people, have been changed forever, but it didn't need to be that way. So years ago, just as that initial crisis took place, I set out to learn and share about what I didn't know. And after a few years, I decided to leave the classroom. I joined the staff at NAMI Delaware, and in that role, I worked with families and educators, service providers, policymakers, addressing critical issues about the continuum of care. And I was fortunate to advocate for and witness the passing of landmark school mental health legislation, addressing the issues like ratios of students to school mental health professionals, and also the requiring of mental health education in schools. And today I do work for the University of Delaware Center for Disabilities Studies. And I'm also a doctoral student at the University of Delaware. And I'm co-founder of the Mental Health Literacy Collaborative. So today, our objectives are to learn about evidence-based mental health literacy and its 4 components, to recognize the connection between mental health literacy and suicide prevention, and identify strategies for decreasing stigma and increasing early intervention, and learn about national efforts to increase mental health literacy in schools. You've probably seen the headlines. The Surgeon General has called the increase of youth mental health needs the defining health crisis of our time. We're seeing increasing rates of mental health symptoms, self-harm, thoughts, attempts, and deaths by suicide. And we know that families and schools and communities are looking for more support because all these trends continue to worsen. And the mental health care system is doing its best to keep up, but it's difficult. And these data are from the Youth Risk Behavior Survey from the CDC. 42% of high school students experience feelings of sadness or hopelessness. 22% seriously considered attempting suicide, and 18% made a plan. This isn't just about young people, though. According to the Mental Health according to Mental Health America, over 50 million American adults are experiencing mental illness. So maybe you're here today because you're an educator, or maybe you're a clinician, mental health professional, or healthcare. Maybe you're a community leader, or maybe you're just someone who's either personally or professionally connected to a person who might be experiencing mental health problems. Or maybe you're experiencing them yourself and you're looking for answers. But first, I want you to know, whatever brought you here, whatever inspired you to show up, I'm glad you're here. And I want to help answer your questions. So please add them to the chat when you think of them, and I'll do my best to address them at the end of our time together. But I want to start with a couple of questions you might have had. They're certainly questions I've asked. How did we get here, and what can we do about it? So this next section is about a popular comic strip. Now, due to copyright, we're not going to share the image, but I'll describe it, and I think you'll recognize what I'm talking about. The comic was originally published in 1959, and it's 4 boxes. In the first box, the little girl has dark pigtails, and she's sitting behind a box that says psychiatric help 5 cents. And there's an empty chair in front of the box. In the next part of the comic, a little boy is sitting in the chair. And the little girl has her head kind of resting, or her chin resting in her hands. And the little boy leans forward and he looks a little worried and he says, "I have deep feelings of depression." The little girl in the third box looks away as if thinking. And the little boy asks another question. He asks, "What can I do about this?" And in the fourth box, the little girl turns back to him and exclaims, "Snap out of it. 5 cents, please." And the little boy sort of looks facing the center and really looks disappointed. Now, perhaps you recognize these children in this comic, and it is from 1959, so it's a little dated, but the idea is I wanted you to have something to kind of anchor where we've been with this conversation. Traditionally, our culture hasn't done a very good job addressing someone who's disclosed concerns about mental health. Historically, we really haven't known what to say. Maybe we've been just as frustrated as that little girl. Maybe if we've been on the side of it as the little boy is, maybe we've been concerned or disappointed with responses we've gotten, or even worse, maybe we haven't shared because we were fearful about the responses we get. So the cartoon was published over 60 years ago. How much has changed? Do people still react like the little girl? Do you think people might feel as disappointed as the little boy? Now, sometimes the mystery or this problem around addressing someone who's disclosed has created this idea of fear. And I'm going to show you a video now. It's a public service announcement from an organization that was founded by Glenn Close. And the organization is called Bring Change to Mind. She and her nephew, Kaylin, highlight a common misperception about mental illness. Now, I want to caution you, the video is about a minute long, and it may be disturbing. It has some jarring images. It has some disruptive sound. And I'm going to ask media services to help me with sharing it. So I'm going to stop sharing my screen at this point.
Hi there. Sorry to disappoint you if you're expecting a lunatic on a rampage. I'm Kaylin, and I've been living with schizophrenia for 11 years. People like me with a diagnosis of mental illness face stigma and discrimination every day. Luckily, I've had the support of family and friends to help me live a full life.
It's time to talk about mental illness. Start the conversation.
So in terms of how we got here, what we can do about it, we have to remember that how deeply rooted misperceptions about mental illness have been in our culture, from the idea of being annoyed, like the little girl in the comic, to the idea of being afraid. So back when I was seeking out that information I shared with you, and I was trying to figure out what I didn't know to help my own child, I learned some fundamental information about mental illness that I'm going to share with you now. It still holds true today. So first of all, it might seem pretty basic, but we all have mental health, and mental illnesses are common and treatable. The reason I share that is, first of all, that mental health and mental illness, though they are distinctly different, are often used interchangeably in conversations. So I want to make a distinction. Mental health is part of our overall health. It's not a binary of wellness and illness. It's complex, and it includes our emotional and psychological and social well-being, and it's inclusive of multiple aspects of our well-being. It affects how we think and feel and act. So remember, mental health is health. And when it comes to being common and treatable, that's something we need to remember. Mental health conditions need to be diagnosed by a medical professional, and they're common. They affect at least 1 in 5 people, and they're also treatable, especially when they're addressed early. The next point I wanted to share is that the average delay between symptoms and treatment is 11 years. 11 years. Imagine any other health problem that you might have that you would just sit with and endure for 11 years. And that's if you address it at all. Because fewer than 50% of US adults actually receive the treatment that they need. So go back to that 11-year idea. So that there are fewer than 50% of people who get help. They're still waiting an average of 11 years. And that means the majority of people aren't getting help at all. The next point kind of goes back to the video we just viewed. People with mental illness are not likely to be violent. You know, just turn on the news after a tragic event involving violence, and chances are it won't be long, and you'll hear someone connecting the event to mental illness. But research shows that people with mental illness are far more likely to be victims than to be perpetrators. We've got a lot of work to do when it comes to eliminating these false notions tying violence to mental illness. Stigma is a primary barrier to seeking help. And we're going to be kind of diving more deeply into that concept in a little while. But the World Health Organization defines stigma as a mark of shame, disgrace, or disapproval, which results in an individual being rejected or discriminated against and excluded from participating in a number of areas of society. And in the case of stigma of mental illness, that exclusion is often excluding people from accessing the healthcare that they need. The next point is depression is a leading cause of disability worldwide. So depression is a global concern. And 50% of lifetime mental illnesses begin by the age of 14, and 75% of them by the age of 24. Maybe these are facts you knew already, and maybe there were some that you didn't know, but I remember when I first learned these, here's what I kept thinking. Why didn't I know these before? And why didn't anyone tell me? And why didn't anyone tell my child? So education is a scalable, proactive solution for addressing and preventing social problems. So looking to education, and specifically looking to schools to help address the youth mental health crisis, is really important. But let's take a closer look at the primary approach we've been using. Think about it this way. What if Smokey the Bear only taught people how to put out forest fires instead of how to prevent them? When it comes to addressing mental health needs in schools and in our communities, our current system is mostly about putting out fires. And we definitely need effective strategies in that area. But doing just that keeps us in a constant responding phase. We can't keep up. Our educators and our clinicians and our families and our communities, they're showing up bravely, and they're doing the very best they can to identify and address the needs that they recognize. But what if there was a way that we could do more in advance? What if we could understand universally about our mental health, regardless of or in advance of any emerging signs of concern? How did you learn about mental health? Who taught you? And in what context did you learn it? Was there information that you received? Was it accurate? And how about now compare that to when did you learn about other parts of your health, your senses, or the systems in your body, or your physical health? We need a shared understanding about a common non-judgmental language when it comes to mental health. Here we are, mental health literacy. So mental health literacy is a tier 1 universal education that covers these 4 components. It includes understanding how to foster and maintain mental health, understanding mental health disorders and their treatments, understanding how to seek help effectively, and understanding stigma and stigma reduction strategies. So the term mental health literacy isn't really new. It was coined in the late 1990s, and it derives from the idea of health literacy. The idea that if we have health literacy, then we ask better questions when we are seeking health care, and the outcomes are better. So that's where it first originated, and it's been refined ever since. And the key points in that refinement are really looking at the idea of it not being only about mental illness. So it's understanding our own mental health and that broad range of what that means, right? And it's also really important to point out the help-seeking part and the stigma reduction part. Because remember, stigma is a primary barrier to seeking treatment. Now, it is an evolving construct, so there are constantly more and more studies being done to look at and refine this idea. But here's what we know. It's universal, it's for everyone. It does not replace treatment. It is not at all treatment, as a matter of fact. It's a literacy. So it can be taught by educators. You don't need clinical expertise. And it can also be delivered separately as in like a class, like a health class, but it also can be integrated into other content. For example, if you're reading a novel in your classroom and you want to tie in these key components that are developmentally appropriate. And it needs to exist beyond a single session. So it's not about bringing a presenter in one day and then you check the box that mental health literacy is done. No, it needs to be reinforced, and it needs to be appropriate in lots of ways. So it needs to be culturally appropriate, developmentally appropriate, and contextually appropriate. So that really means that when we're looking at how to deliver mental health literacy, we have to think about who we're speaking with and what the needs of that population are. a mental health literacy training for law enforcement, for example, is going to look different than a mental health literacy program in a school. Now, maybe you're wondering, what about SEL? And so if you're connected to education at all, or if you are a parent or you have children who are in schools that are learning about SEL, I wanted to really touch on the connection between SEL and mental health literacy. So SEL is social emotional learning. And here in Delaware, we have strong foundation of SEL in many, many schools. But mental health literacy is not the same as SEL. We like to think of it as like math and science. Math is a separate subject than science. They're separate concepts, right? But they work together and they complement one another. You need them both. And that's the way SEL and mental health literacy can work. So just a quick recap, SEL is looking at things like healthy identities and managing emotions and relationships, goal setting, responsible decisions. But mental health literacy is really looking at our mental health and understanding how to maintain our mental health, how to address signs early, how treatments work, decreasing stigma around mental health problems, and understanding and recognizing how to seek help. So this is a quote from a colleague from Canada. His name is Andrew Baxter, and he is the mental health literacy project lead at Alberta Health Services. And I loved what he said so much that I asked him if I could quote him and put him in this presentation. We were talking about SEL and mental health literacy, and this is what he said. There's a difference between identifying and empathizing with the feeling of sadness and recognizing the symptoms of depression and knowing how and when to seek help. So this is a good way to kind of capture the idea of how SEL and mental health literacy are different, but they do complement one another, and they are really important for our understanding. So the World Health Organization says depression is the leading cause of disability around the world. And I did share this earlier. And depression, according to the American Foundation for Suicide Prevention, is the condition that's most frequently associated with suicide-related outcomes. So I wanted to take a moment now, during the month of September, National Suicide Prevention Awareness Month, to address the topic of suicide. It's a complex issue, and it's often, when someone dies by suicide, it's often the result of a variety of factors, and it's difficult to talk about. It's difficult to understand, and it may be something very personal to you or to those you care about. But talking about suicide and learning about it is really important. In fact, it can save lives because suicide can be prevented. I want to make sure you know about 988. The Suicide and Crisis Lifeline is now a nationally recognized number, just as easy to remember as 911, but very specifically focused on what they do. It's a 24-hour, 7-day-a-week access point by phone or by text, where you can reach out in English, in Spanish, in American Sign Language. It's easy to remember, and that was the goal. We didn't want people to have to remember some big, long 800 number in the moment that they might need help, or that someone they care about might need help. And remember, part of mental health literacy is understanding about help seeking, understanding where to turn, understanding how to do it. So that's one of the reasons I wanted to make sure that you were familiar with 988. And later at the end of the session, we'll be uploading a more thorough document that will share a little bit more about the 988 work. But it's a good access point for you now. And if you want to just take a moment and remember that, put it in your phone, I recommend it. So in terms of suicide prevention, though, we're not going to be creating right now during this session any sort of prevention training. But if you have interest in a suicide prevention training, I would love to help you find resources, and I'd be happy to do that offline after this presentation. But for now, I just want to make sure that you recognize that suicide prevention is a critical part of mental health literacy. And of course, I'm going to share a few more slides related to suicide, one being about risk and another being about stigma reduction strategies. So in terms of risk for suicide, some groups have a higher risk. So veterans under the age of 45, suicide is the second leading cause of death for them. And in the US, almost half of all suicides are adults ages 35 to 64. LGBT youth attempt suicide at a rate 5 times higher than their heterosexual peers. And adults with disabilities report frequent mental health distress, which is a risk factor for suicide, at almost 5 times the rate of adults as adults without disabilities. And a key point too is that suicide is the second leading cause of death for people ages 10 to 14 and 20 to 34. There are things we can all do to help decrease the stigma. And thinking about suicide in terms of language really matters. So the information I'm sharing here is from the International Association for Suicide Prevention. And there is a document I'll share at the end too that covers this as well. But just there are some ways that we can go about talking about suicide that help decrease the stigma. One being, we don't want to say committed, because when we think of commit, we think of a crime. Instead, we recommend saying died by, or it took their life. Instead of talking about attempts in terms of unsuccessful or successful, just call them attempts. Because if you're saying unsuccessful attempt, what are our goals here? Our goal should not, we shouldn't be like creating a judgment value on this. And it's a really important point to not talk about method or location or details around a suicide death. It's most important for journalists or any sort of reporting that might happen, but also in our conversations, in the work we're doing, in the spaces that we're in, we actually put people at risk if we provide too many details, because you don't know what other people are experiencing or might be that might generate strong feelings in them. So we want to reduce those risks by not being specific. And it's just important to think about being conscientious around about our language, because we want to encourage people to get help. Remember, suicides are preventable, and people who feel stigmatized are less likely to get help. So in thinking about language, we can explore that beyond the topic of suicide. And in thinking about language, mental illness and substance use disorder are topics that really require careful language and can really, really address stigma when we're thoughtful about our language. First of all, we want to use person-first language. Instead of saying that person is a schizophrenic or that person is schizophrenic, that person is a person with schizophrenia. Instead of referring to a group of people as the mentally ill, say people with mental illness. And instead of saying addict, say person with substance use disorder. We also want to avoid negative judgment. Instead of saying substance abuse, which implies a choice and it certainly shows judgment, just say misuse or use, substance use. And another key point, and this one's hard, but I always like to mention it. Be mindful of the words that we use just every day that could be stigmatizing, crazy, insane. How many times do we hear about that when we're hearing about discussions related to the weather or any other thing? And as a former English teacher, I should also mention that not only are words like crazy and insane harmful to and stigmatizing, they're also not very specific. So as an English teacher, I would recommend just thinking about, what do I really mean when I say this is crazy? What am I really trying to say? And you'll find yourself actually using better language and being more descriptive. And overall, when we're thinking about language, it's just really important to emphasize hope and the possibility of recovery. So we know the problem of the mental health crisis is complex, and there's no one singular solution. It's going to take a lot of passionate people representing lots of areas that intersect with mental health to address the crisis. But going upstream is a really good place to start. Desmond Tutu said, there comes a point where we need to just stop pulling people out of the river. We need to go upstream and find out why they're falling in. So I hope by now you agree that mental health literacy is imperative, and it should be foundational. It should be foundational knowledge universally. We have a lot of work to do to make that happen, but we can look to schools for an opportunity to begin that work. So the Mental Health Literacy Collaborative is a national group representing education, mental health, research, policy, advocacy from states, national organizations, and even international ones. And we're all focused on the singular mission to make evidence-based mental health literacy foundational in education, pre-K through grade 12. And our work is focused on these 4 domains: education and advocacy, programming implementation, research and evaluation, and policy support. We want to build shared knowledge and convene champions to drive quality implementation and to guide research and policies and practices. Now, the work we do does not include vetting specific programs. We do have a partner organization that does that work. So looking to the Mental Health Literacy Collaborative about specific programming isn't necessarily helpful at this point. We see that part of our work down the road. But as we're ramping up, we refer all specific endorsement conversations to happen with Chad's Legacy Project, because they have an online library of mental health literacy programming resources. So I'd be happy to connect you if you have that interest. We offer a monthly community of practice where people can come together virtually and discuss implementing mental health literacy in schools. And we do not record our meetings because we want to have honest conversations about how the work is getting done. We have passionate people coming together, and they're showing up bravely, just as I talked about, because they want to talk about the barriers that they might be facing or the strategies that they're developing to bring mental health literacy into their schools and their communities. Our team is growing. We've only just begun. We launched this spring, and we're developing our plans now and assembling advisors. We have experts that represent so many spaces. We have family members, young adult peers. We have advocates representing underserved or unserved communities. We have state and national leaders of schools, universities, practitioners and researchers and leaders in mental health services spaces. We have policy and advocacy leaders. Everyone coming to the table really has valuable perspective. And we're really focused on the mission of mental health literacy in schools. And if you'd like to learn more about it, you can certainly visit our website. It's themhlc.org. So I'm wrapping up now. I'd be happy to take any questions that you might have. That's my email if you'd like to reach out, and I will stop sharing so we can hear some questions.
Thank you very much, Annie. And we'll begin with those questions now.
Okay.
When we think about the time lag between noticing symptoms and getting treatment, what is your advice to parents of minors and/or educators who recognize symptoms and offer help to their children, but the children are not interested or willing to participate?
Yeah, I mean, that's stigma right there. I think the more you can give agency to the young people that you're talking to and give them the feeling that they're at the wheel. When you're thinking about, like, I always think about teaching my children to drive. Oh, if you've ever done that, you know what that's like. The idea being that you really just want to grab the wheel and you want to tell them how to drive, right? But they're never going to learn how to drive by themselves if we do that. It's really hard as educators, as parents, as caregivers, to see a need in our children and not just take over for them. But really, it's fear and it's stigma that keeps our children from recognizing or asking for help, acknowledging that they need help, or even having trust in that there is help available. So maybe thinking in terms of how can you shape your conversations, making mental health conversations be a little bit more kind of common. And then also talking about strategies in general, about what people can do, what access points there are. And then really just that recurring, how are you kind of conversation. And one final point I would say is mental health is health, right? So maybe framing the conversation with your children in terms of, I often share the story of my older child tore his ACL in high school. And I used that to kind of be the comparison. When that happened, there was no question that my child would go see the doctor, would go to the treatment that they were, assigned, and would follow through on all the things they were expected to do, because they wanted to be able to walk again and to play basketball and do all the things, right? So use mental health as a health conversation and ask in terms of, if this were something else, or do you remember that time when you had whatever? What did we do to solve that problem? So that's another kind of direction you could take. I don't think there's any one solution to how to solve the problem. I think universally we need to have more conversations around it. And so I think you've taken the first step just by showing up today. So thank you for doing that. Hope that's helpful.
Thank you, Annie.
Mhm.
Tabitha, I know that you are adding quite a bit of information into the chat for some people who are asking about resources.
Right. So we do have a question about the resource library. And Annie, I'm going to let you know that I've shared the link to
Great.
the Mental Health Literacy Collaborative.
Okay.
And I have put the 988 fact sheet in the chat and the
Great.
Words Matter suicide language. So are there any
Great.
additional resources that you would want to point people towards? And I'm happy to put the link in the chat if there's something you think of.
I think what you have there is great. I think if anyone wants to reach out to me on any particular, like, personal resource needs, I'd be happy to respond to those. But for now, that should do it.
And are you okay with my putting your email address?
No, that's totally fine. Yep.
Okay.
Mm-hmm. Yep.
I will be sure to add that. And we do
Okay.
have one other request to reshare something, and that is the quote that you had describing the difference between SEL and MHL.
Mm-hmm. Yeah. So there's a difference between identifying and empathizing with the feeling of sadness and recognizing the symptoms of depression and knowing how and when to seek help.
Okay, thank you. Annie, you mentioned that fewer than half of the U.S. adults with mental illness receive treatment. Is that what we also see in Delaware? And what are some of your primary recommendations of how we can make improvements in that percentage?
I don't have data offhand on that piece, the Delaware piece, but I would assume that that particular statistic has really gone unchanged in the last decade that I've been doing this work. So it's kind of hovered around 50% every year. And it's, one good resource for that is the Mental Health Association, or I'm sorry, Mental Health America, MHA. They do work on that every year to sort of shine a light on that. In terms of what was the second part of the question? What can we do?
What are some of your primary recommendations for making improvements in that percentage?
Oh, well, I mean, I think mental health literacy is a primary universal strategy we could all be taking. It's really, when you think about what the mental health literacy components are, those 4 basic components, it's not a big lift to understand in general what they are. Even if you don't, pursue deep knowledge in it, if more of us had that foundational understanding well in advance of any concerns that we might have, we would be better equipped to resolve the problems we might be feeling, but also help someone else resolve those problems.
Okay. I like your explanation of how language matters. Where are we as a population in adopting and using appropriate language?
Well, I think we've gotten a lot better, I will say. I think even in the short time that I've been doing this work, about a decade or so, I think we've gotten a lot more mindful about how we say things, what we say, how words matter. For example, in 2017, 18, I might have my years wrong, but there was a series of suicide deaths that were high profile, Robin Williams being among them. And during that time, there was a huge push to be thoughtful and mindful about reporting on suicide. And since then, there is now a website that's dedicated to journalists knowing how to do that carefully. And if you've ever seen in recent reporting, there's always something in the report that will warn you about, content may be disturbing to readers, and it also will give you resources directly to get help right then. That is a direct result on the language awareness that we've been developing. And I would also recommend that, or remind you that, think of the R word. When I was growing up, the R word was used pretty regularly. It's not anymore. So we can, as a culture, shift our language when we're paying attention to it. So that would be my thought on that.
I want to continue to encourage people, if they have questions, to put them in the chat. I was somewhat surprised about the World Health Organization's finding that depression is the leading cause of disability worldwide. Does the World Health Organization provide an explanation and data behind that, or what do you believe is driving that number?
That's a great question. I'm not sure I have a good answer for that, other than I think they're looking at employment. I think it's connected to employment and employment reports. I know that I've seen data around, in looking at the workforce, what reduces workforce productivity and health concerns related to that. And I think it's tied to that, but I don't know that I have a good answer. So I could certainly look into it and see if I could get a better answer. If you want to reach out to me on an email, and we can follow up.
I'm sorry, Tabitha, did you have something there?
Yes, so I wanted to ask, I apologize if I missed this, but the mental health literacy collaborative, I understand that it's really just getting off of the ground. And so there's probably a lot of different goals. Will there be a goal, and it is nationwide? I don't know if you mentioned that, but I know that it's not just local. It's not, in fact, is it international? Is there anyone?
Well, Yeah, we
Technically
set out to
Canada.
be national, but we have advisors from Canada who are frankly really critical in this work, because Canada has really been the source of landmark work in this area, and the leaders of the work in Canada are connected to us. So I'm thrilled that we have that connection. So I guess technically we're international. That wasn't the primary goal, but it's very exciting.
So my question about that was, and again, like I said, I apologize if I missed this, but will there be effort by that group to try to influence legislation? I know that there were 3 bills that pertain to mental health that were passed in Delaware in the last year. And so I wanted to know if you could, is that something down the road or?
So as a national group, our goals were really focused in supporting policies that existed and then helping. So in thinking about policy, little p as opposed to big P legislation, right? Legislation is one avenue, but what we found is that passing legislation in any spot, in any state, doesn't solve the problem. It gets us started thinking about it, but unless we have the network for implementing the actual plan, it might not go well, right? So what we found is that and what we continue to see is that even in states like Delaware and New York, passing legislation is a part of it, but we have to do more to help build the structure for the planning. So we don't have goals per se to pass legislation necessarily. There may be times to maybe in some states that we're working with, because we have, for now, we've connected to I think 10 different states through just word of mouth. We're not really promoting our work, but those 10 states, about half of them have legislation. I think I'm guessing that right, but it's not everyone. But the point is, that doesn't mean the legislation will solve it. So to answer your question, no, our goal isn't directly to pass legislation. It's more to think about supporting existing legislation and help refining models of to respond to legislation. At the federal level, that there may be an opportunity to look when we think about, and I don't know if legislation is the right answer, but we're looking at national efforts around refining what mental health literacy education looks like, and looking at standards or competencies. And that may or may not be regulated in some way. But yeah, I mean, we have big idea goals, but right now what we're focused on is the education and advocacy piece, because even people in the work aren't clear on the distinction of what mental health literacy truly is and how it can work. So it's not for fault of anyone. It's just really nobody's talking about it yet. So we're excited to be where we are, and we're moving rather quickly to try to keep up with the interest.
Okay, Annie, thank you. We have a few more questions that are coming to the chat. One question is, the data about youth risk was pre-COVID. Do you have any updated data about youth prevalence? We know the pandemic exacerbated so mental illness in unbelievable ways.
Right. Yeah. So the data from 2021 from CDC was sort of mid COVID, and they continue to show the trends are worsening. I don't have numbers right off the top of my head, but I can tell you that the CDC put out a decade's worth of studies or reports and showed the trends across multiple areas continuing to decline. And in terms of the pandemic, you're right. I mean, they exacerbated things. They also highlighted things. And I don't think we're, I don't think we were ready, obviously, to respond to the need we had before COVID. And now it's just become more problematic. Another area of interest that we're following is social media, and how social media has played a part in our young people's, worsening mental health. there's some good data around that, and also some reports on specific groups of young people and their declining mental health. So I think we're really looking closely at it. And I think the numbers, just to your point, have worsened, but I don't have any particular numbers right off the top of my head.
We have just a couple more questions.
Okay.
We're going to try and get to in the few minutes that we have left. Tabitha, you want to take the next one?
Sure. So this is where can I find more information related to mental health and people with disabilities? I want to have a session for the advocacy group I volunteer with and have had trouble finding presenters. Do you have any suggestions?
Oh, that's a great question. Well, you came to the right place. Center for Disability Studies. We're doing a lot of work in that space. I'd be happy to follow up with you if that's a local group. Maybe I can help with that. I'd probably want to know a little bit more about the group you're thinking about, and in terms of, are you looking for data? Are you looking for services? Are you looking for resources? There's so much to talk about in terms of mental health needs, just in general. But I'd be happy to try to help with that if you want to follow up with me.
So one final question, Annie. What strategies are planned to bring youth voices to the table in identifying perspectives, challenges to enhance MHL?
Well, I can tell you, as our collaborative grows, we have young adult advisors. For that very reason, we absolutely recognize the need for young people to share their experiences. And I can tell you that some of our national partners are doing excellent work in this space. NAMI National, I shared that I worked for the Delaware chapter of NAMI, but NAMI is a national organization, and their work nationally to highlight young adult voices. They have a project called NAMI Next Generation, and those leaders are connected. Well, one of them serves on our advisory, but those leaders are connected to this work very closely. Another group that's doing similar things is Mental Health America. They have a similar group, and the name escapes me right now as to what it's called, but again, it's young adult voices. So there are multiple groups doing this to highlight their first person experiences. And I called upon NAMI just now because they recently put out a study, a survey that they had done nationally from teens about what they are asking for. And 2 in 3 said they want to learn about mental health in schools. So there are lots of places that we can look to national leaders talking about this with young adults, and our work includes young adults for that very reason. And I think high schools are another good place to go. We just, right now, as our group is growing, we haven't expanded to high school students yet, but we have that in our sights because it's incredibly important.
Thank you. Well, we are at the end of our hour.
All right.
And I want to thank you, Annie, very much for leading our presentation today. Want to thank everyone who took time out of their day to join us for today's presentation. Also want to remind everyone that at the conclusion, you will receive the survey about today's event. We ask that you complete it and return it to us today or tomorrow. And I hope everyone has a pleasant rest of the day. Thank you once again.
Thank you.